Hi, I would first want to thank the jury and the organizers for the prize and giving me the opportunity to present our work, which I'll present first with a little bit of background of the previous work we have done in order we can understand it a little bit better, and we'll finally come to the discussion on what are we doing currently to pursue these ideas and the hypotheses that this work has raised. Because this is a story that started a few years ago, back in 2008. I was doing my PhD in a hospital clinic, and it's a story on how one completely unexpected finding leads to new hypotheses, and you will see how it has come to this idea of possible interactions between A-beta and phospho-tau in CSF that might impact and affect brain structure in preclinical AD. And this is the work that started. This was a completely unexpected finding. Back then, we were studying familial AD, presenilin 1 mutation carriers that you know are the most prevalent cause of familial AD. And the question we were asking ourselves is how early could we detect changes in cortical structure, brain structure? The London's group had published some previous work, and they have shown that they were able to detect some changes 3 to 5 years prior to a theoretical symptom onset. The difference in our cohort was, however, that we have a much younger cohort that was several years away from symptom onset. And when we wanted to assess whether we could detect atrophy or not, those were the ideas we had, we were quite surprised that instead of atrophy, we found cortical thickening in blue. And we found that cortical thickening, I have to say, with every software we had there, SPM, FSL, FreeSurfer, it was extremely difficult to publish this paper. No one would believe thickening was a hypothesis in Alzheimer's disease. And one thing that struck us, instead, in addition to this statistical analysis that we had to perform, was the specificity of the areas. These areas are not randomly distributed across the cortex, but as you can see, they are in AD vulnerable areas, so what has been called the AD signature. And there is a nice correlation between the adjusted age, that is how far they are theoretically from symptom onset, and the cortical thickness in those areas. So the question here was, is this something specific of familial AD, or if you wish, of this cohort of familial AD, or is something that we might find also in sporadic AD? Of course, we did not have any more mutation carriers to assess, but we were also constructing a cohort to study sporadic preclinical AD at that moment. And there, of course, we did not have any genetic marker, so we thought which was the earliest biomarker we have to detect changes in AD. And it was, of course, as you know, A-beta. But if you are to believe that you might find thickening prior to thinning, linear relationships may be too simplistic to assess this issue. And that's exactly what we found. We found that the relationship between CSF A-beta values and cortical thickness in several AD vulnerable areas was not linear, but quadratic. As you can see, as we move left to lower CSF A-beta values, that is more pathological, you start with an increase in cortical thickness and then a decrease with very low CSF A-beta values. And in fact, when you take this middle tertile with the transitional CSF A-beta values from normal to pathological ones, and you compare it to the high tertile, you do indeed find cortical thickening also in AD vulnerable areas. But of course, we had these questions on why one process, such as amyloidosis, is at the beginning associated with thickening and later on with thinning. Then I changed hospital. I moved to the hospital of Sant Pau, and we were constructing the cohort, a new cohort. And while we were doing that, these two papers appeared, which showed that both atrophy and clinical decline in preclinical AD only occurred when you had both CSF A-beta and Phospho-Tau abnormal values. So we thought that maybe there we had a clue. Maybe Phospho-Tau was a confusion factor, or maybe there were interactions with between A-beta and Phospho-Tau. So this was the main hypothesis and objective of this work, which was published last year in Annals of Neurology, in which the objective was to disentangle the possible interactions between CSF A-beta and Phospho-Tau levels, which might impact brain structure. And the hypotheses were quite simple. Atrophy would only occur in the presence of both A-beta and Phospho-Tau. But CSF A-beta, in the absence of Phospho-Tau, would be associated with increased cortical thickness. We took advantage of ADNI, which you all know, a multi-center North American study, and we took all healthy controls that had a 3 Tesla MRI and available CSF A-beta values, a quite old cohort, 73 years of age. And the first question was simple. Are there interactions between CSF and Phospho-Tau affecting brain structure? And for that purpose, we first divided the subjects into A-beta positive and A-beta negative, Phospho-Tau positive and Phospho-Tau negative. You have 4 groups. And we check if there are regions of the brain suffering from this kind of interactions. And indeed there were. And when you take that into box plots to analyze the directionality of the interaction, you can find that in those subjects that are A-beta positive, this red rectangle, when you have amyloid positivity in the absence of Phospho-Tau, you have increased cortical thickness. But in the presence of Phospho-Tau, the directionality changes towards cortical thinning. This is another way to look into the results. Here you keep one biomarker dichotomized and you assess the other in continuous manner. And this let us assess the A-beta cortical thickness relationship separately from the Phospho-Tau cortical thickness. So let's look first at the top row, and we ask, are there these kind of interactions? And as you can see, yes, there are. And I would like you to look at the blue dots. The blue dots are those subjects that are Phospho-Tau negative. In the x-axis, you have the CSF A-beta values. And you can see that if you are Phospho-Tau negative, the more pathological your A-beta values are, the thicker your cortex is. Conversely, when you analyze the Phospho-Tau cortical thickness relationship in the bottom row, what you find is something similar some way. That the red dots, and the red dots are those subjects that are A-beta positive, only in those subjects, you find a negative correlation between Phospho-Tau values and cortical thickness. So the take-home message from the interaction analysis is that the correlation between one cortical thickness and one biomarker is modified by the status of the other dichotomized biomarker. And whenever you have interactions, it is always a good idea to stratify the results. So if you do that and you want to assess the A-beta cortical thickness interaction in Phospho-Tau negative subjects, we also found nice areas of correlations between cortical thickness and A-beta values, in the sense, again, that with decreasing A-beta values, that is pathological, you have increased cortical thickness. But you do not have any significant correlations between A-beta cortical thickness in Phospho-Tau positive subjects. And if you analyze now the Phospho-Tau cortical thickness relationship in A-beta positive subjects, you still find nice correlation, nice clusters of correlation between higher Phospho-Tau values associated with thinner cortex. So that is, only in the presence of A-beta is phospho-tau associated with decreased cortical thinning. So the conclusions of the work was that interactions of biomarkers determine a two-phase phenomenon of pathological cortical thickening in relation to decreasing CSF A-beta, followed by atrophy once the synergistic toxic effect of phospho-tau predominates. And this, we think, has practical implications, and specifically in clinical trials. If we are to select patients based only on amyloid imaging, we will not be able to detect those who are phospho-tau positive or phospho-tau negative. And if we are to use MRI as a surrogate markers of efficacy, we might expect different changes. Maybe if we take out the amyloid, we would get atrophy instead of thickening. And this is exactly some of the paradoxical findings that in some trials with anti-amyloid drugs we have found. As I said, we are continuing with this line of research, and we first want to replicate and better understand this amyloid-related cortical thickening. And the hypothesis we have is that this amyloid-related thickening is mediated by inflammation. And the MRI, even the MRI, might help us to study this phenomenon. And I'm quite happy to present this here because this replication cohort, or this new cohort, has been funded in part by the CIBERNED because of the signal study. The PI is Dr. Alberto Lleó, who was able to build up a multi-center Spanish cohort study of biomarkers. And for this work, we have selected patients from 3 centers in Spain: CIT Alzheimer in San Sebastián. The PI is, as you know, Pablo Martínez Laje, Valdecilla in Santander, Pascual Sánchez Juan, and ourselves in Sant Pau in Barcelona. We've been able to recruit quite a large number of healthy controls, much younger. They are below 60 years. Please don't pay that much of attention to the levels of the biomarkers. It's completely different technologies. This is ELISA, this is Luminex. And as you can see, this is much younger, very few phospho-tau positive subjects. But what we are happy, this is preliminary data. We are currently working on that, but we are quite happy to show that amyloidosis, also in this cohort, with very stringent criteria, is associated to cortical thickening in several areas. So, what is the rationale behind this thickening? We think that there are several lines of evidence that might justify these results. The first one is from pathological studies. And as you can see, it has been previously shown in pathological study, I repeat, that those subjects, as IMAD, those subjects that have pathology in their brains but not any clinical symptomatology, have indeed bigger neurons, bigger nucleolus than healthy controls with no pathology. And with the progression of the disease, you start to get atrophy pathologically. In animal models, some animal models of Alzheimer's have shown larger brains and more synaptic contacts. And of course, we have inflammation, astroglial and microglial inflammation. We've heard quite a lot of that, and I would love to discuss what kind of biomarkers we could use to detect this kind of inflammation. But if you think, and we were thinking quite a lot about that, what would all of these have in common? Larger neurons, more cells, or more synaptic contact. We came to the conclusion that all these 3 things would increase the intracellular space in the cortex. And this has some importance because the water does not move equally intracellularly and extracellularly, because there are a lot more membranes intracellularly than extracellularly. So, and we can measure that by means of the diffusion tensor imaging. And specifically, mean diffusivity is a measure of the global of the movement of water molecules. So, theoretically, if you have a healthy control with 50% of water intracellular and 50% of extracellular water, if you have this cortical thickening, I don't care if it's asymptomatic mutation carriers or brain amyloidosis, you would increase the relative amount of intracellular water. And the opposite would occur if you have atrophy. And we could hypothesize that the directionality of the mean diffusivity changes would be opposite. And this is also preliminary data. This is what we are finding. This is unpublished work in preparation, but we can find that this A-beta group has widespread clusters of decreased mean diffusivity, whereas there are only a few, and subcortical, only 2 subcortical clusters mainly, of increased mean diffusivity. That is, it seems we can also detect this two-phase phenomenon in DTI, in cortical DTI. And this has some importance, because if you have cortical thickening and then atrophy, you would have a phase in which you would have pseudonormality. Those subjects going down will have normal cortical thickness, but maybe that cortical ribbon is pathological. We are also looking at longitudinal data. We don't have that kind of data yet for the signal study, but we're analyzing the ADNI data, and we have, I won't show you anything there, but we have some promising results there. And with that, I would like to end thanking the great group of people I work with in Barcelona, in the Hospital of Sant Pau, especially Alberto Lleó, who is the head of the unit, and this person here, he's in red, he's Eduardo Vilaplana, he's the engineer, he's the first author of this paper, and of course I will share the prize with him. Thank you very much.